Welcome to this explainer. If you've ever felt like you need a medical degree just to correctly sequence hypertension, cardiorenal, and systemic complication codes, trust me, you are not alone. It gets incredibly complex, incredibly quickly. But today, we're going to make it crystal clear by breaking down the absolute core rules you need to know.
Here is our roadmap for today. 1. Hypertension fundamentals. 2. Hypertensive heart disease. 3. The cardiorenal connection. 4. Navigating CKD and ESRD. 5. Systemic hypertensive complications. And 6. We'll wrap it all up with a clinical case walkthrough.
Starting off with Section 1, Hypertension Fundamentals. Now, hypertension, as we all know, is high blood pressure, but from a clinical and coding standpoint, it's not just a one-off bad reading at a doctor's visit, right? It's a condition where the pressure in the vessels is persistently elevated. And the reason this matters so much, and why getting it right on the claim is absolutely crucial, is because if left untreated, this persistent pressure dramatically spikes the patient's risk of devastating events like heart attacks and strokes. This perfectly illustrates what's happening mechanically inside the body. You've got your systolic number, that's the top number when the heart actually contracts, and the diastolic number for when the heart rests between beats. Once you cross that threshold to a systolic pressure of 130 or higher, or a diastolic of 80 or higher, that indicates hypertension. It is literally the physical force of blood battering against those artery walls. Moving right along to Section 2, Hypertensive heart disease.
Okay, let's look at the absolute golden rule here, the width guideline. Honestly, this is going to be your best friend when coding hypertensive heart disease. For specific heart conditions classified under the I-51.4 to I-51.9 range, we're talking things like left ventricular hypertrophy or myocardial degeneration, you must assume a cause and effect relationship with the hypertension. You do not need the doctor to explicitly write the words due to. You just assume it and combine them into code I-11.9. The only exception, if the provider explicitly documents that the two conditions are completely unrelated. This is a massive efficiency booster, but you've got to know when to apply it.
All right, down to the kidneys. In Section 3, the cardiorenal connection.
Things get really interesting when we look at the combo deal of hypertension, heart disease, and chronic kidney disease. When a patient has hypertension with both heart and chronic kidney disease, we jump straight to the combination category I-13. So, for example, if you have hypertensive cardiorenal disease with heart failure and CKD stages 1 through 4, your base code is I-13.0. But you aren't done. You've got to use additional codes from category I-50 to pinpoint the exact type of heart failure and category N-18 for the specific stage of the CKD. It's like a giant puzzle. You often need 2 or more codes to tell the complete clinical story.
Let's dig a bit deeper into that in Section 4, Navigating CKD and ESRD.
ICD-10 categorizes CKD into 5 stages based on severity and GFR. It's a pretty clear progression. You stage it from 1 to 5 based strictly on what's documented. Then you have N18.6 for end-stage renal disease. But pay close attention to step 4 here because this is critical. If a patient has an AV fistula or shunt created for future dialysis, you do not code Z99.2 for dialysis dependence if they haven't actually started the process yet. Only code Z99.2 once that dialysis has officially commenced. And this brings us to a massive compliance trap that catches coders all the time. Normally, standard CKD staging is coded strictly by the documented stage, right? Stage 5 is N18.5. Simple, but if the patient has CKD that is documented as requiring chronic dialysis, a special inclusion note kicks in. You completely bypass their documented stage, even if the doctor specifically wrote CKD stage 5, and you jump straight to N18.6 for end-stage renal disease, paired with Z99.2 for the dialysis. The requirement for chronic dialysis overrides the standard stage numbering every single time.
Let's look outward now in Section 5, Systemic hypertensive complications. When hypertension damages other organs, the brain is obviously a primary concern. Hypertensive cerebrovascular disease happens when high blood pressure damages the blood vessels up in the brain, potentially leading to a stroke or other severe neurological issues. For these specific complications, the sequencing rule is ironclad. You sequence the neurological condition or stroke first from that I-60 to I-69 range, followed by the hypertension code. The stroke always takes the primary spotlight.
Now moving to the eyes. For hypertensive retinopathy, you definitely need both the eye code, which is H35.0, and the blood pressure code from I-10 to I-15, but unlike a stroke, there is no mandatory eye code first rule here. The sequencing is determined entirely by the primary reason the patient walked into the clinic that day. If they're there primarily for vision issues, the retinopathy goes first. Just in for a hypertension follow-up and the eye issue is secondary, then you sequence the hypertension first.
If you encounter hypertensive cardiomyopathy, it's a mandatory two-step coding process. You can't just use a generic cardiomyopathy code. First, you establish that root cause by assigning I11.9 for hypertensive heart disease. Then, you tack on an additional code I43, which is for cardiomyopathy in diseases classified elsewhere. It beautifully paints the clinical picture that the heart muscle disease is a direct result of the systemic hypertension.
So, what if the documentation clearly states the patient's blood pressure is totally out of control? Sometimes the doctor will describe the hypertension as resistant or uncontrolled, meaning it is stubbornly high even on multiple meds. Clinically, that's alarming. But from a coding perspective, you still stay right within the primary I10 to I15 categories. There's no special separate block just for resistant hypertension. You categorize it exactly as you normally would.
All right, let's put all this into practice with Section 6, Clinical Case Walkthrough.
Here's our patient's history of present illness. We've got a 68-year-old male presenting for an evaluation of gradually worsening exertional dyspnea, basically shortness of breath when he's doing routine stuff like climbing stairs, over the past 4 months. He denies having any chest pain, dizziness, or orthopnea. But look at this. His home blood pressure readings are averaging high, right around 150 to 160 over 90 to 94.
Moving on to the physical exam, the clinical findings confirm that elevated blood pressure at 158 over 92, right there in the clinic. The cardiovascular exam shows normal heart sounds, but does note some trace ankle edema. His lungs are clear. But here is the absolutely critical part for us as coders. The provider explicitly documents that there are no current signs of heart failure, no JVD, and no rails in the lungs. So put on your auditor hat for a second. Based on the WITH guideline and this specific clinical documentation, how would you translate this presentation into a squeaky clean, compliant ICD-10 claim? What codes immediately jump out at you?
Here's the rationale. First, we identify the primary hypertension using the I10 to I15 block. Second, because heart failure was explicitly ruled out in the exam, we absolutely do not assign any I50 heart failure codes, despite his shortness of breath. Finally, we've got to look closely at the final assessment. Did the physician actually diagnose a specific heart condition from the I51 block that would trigger our WITH guideline combination? If yes, we combined into I11.9. If they just diagnose plain old hypertension alongside a symptom of shortness of breath, we code them separately. You always have to read that final assessment super carefully.
Understanding the mechanics of hypertension coding is about so much more than just picking a number out of an index. It's about accurately reflecting the severity and the systemic connections of your patient's disease. So, I'm going to leave you with this. Are your team's claims consistently assuming cause and effect to capture these complex combination codes? Or are you leaving critical clinical accuracy and potentially the true risk profile of your patients on the table? Definitely something to think about. Thanks for joining me on this explainer, and keep coding with confidence.